Welcome to today's webinar, which is on end-of-life considerations for people living with ALS and MND. For this webinar, we have English and Spanish captions available. If you're joining us live on Zoom, please check the chat box as we are adding the instructions right now. And if you're watching the recording, you'll find the instructions for the captions in the video description, and that will tell you how to activate the subtitles. A big thank you to our sponsor, Biogen, without whom this webinar series would not be possible. We really appreciate your support. For those of you who don't know me, I'm Catherine Cummings, the Executive Director of the International Alliance of ALS MND Associations. And I'm joined today by an incredible panel who will provide you with their input on a difficult but very important topic, end of life. This is the last in our care series this year. The recording of the previous webinars you can find on our website or our YouTube channel. Part 1 focuses on what you need to know at diagnosis. Part 2 addresses the ongoing needs of ALS MND. And for today, Part 3 will discuss the end of life. We have an incredible award-winning panel. Our moderator is Carol Burks from the Motor Neuron Disease Association of Australia, also winner of the International Alliance's Humanitarian Award in 2020. And with 20 plus years experience supporting the ALS MND community, not only in Australia, but globally, Carol is a phenomenal speaker. Carol was also part of the Alliance's board of directors and was its chair from 2013 to 2017. Joining her is Dr. Adriano Keogh. He is a professor of neurology and a director of the ALS Center at the University of Torino. And he's also a director of the ALS Expert Center in Torino that aims for optimal diagnostic, workup, care, and treatment for patients with ALS and other motor neuron diseases in Piedmont. He is a member of the Alliance's Scientific Advisory Council and the 2021 winner of the Forbes Norris Award. And Dr. Melinda Kavanagh is a licensed clinical social worker and associate professor in social work at the Helen Bader School of Social Welfare at the University of Wisconsin-Milwaukee. Dr. Kavanagh is a leading expert in young carers in ALS MND. She has presented both nationally and internationally on her work and has published 5 books for children, youth, families, and schools on how to help youth understand ALS MND, caregiving, death, and dying. She is also the winner of the 2021 Allied Professional Award. So when I said it was an award-winning panel, I wasn't kidding. We will also hear from Orlando Ruiz, who unfortunately can't join us live, but he will be sharing his experience and viewpoint as a person living with ALS MND on this very important topic. I will now turn over the microphone to Carol Burks, our moderator for today.
Thank you, Kathy, and welcome, hello to everyone tuning in to this third and final webinar in the ALS MND Care series to discuss end-of-life care and considerations for people living with ALS MND. I'm very much looking forward to moderating a discussion on this very important, but often sensitive and difficult topic. Just a reminder that if you are tuning in live, we will be taking questions at the end of the session, and that you can write questions in the chat box or the Q&A feature throughout the discussion. And we will endeavour, time allowing, to answer your questions. I'd now like to just invite the panelists to introduce themselves and say hello. Dr. Keogh, perhaps we can start with you.
Yes, I am Adriano Keogh. I am a professor of neurology in Torino, Italy, and also the chair of the ALS Center here. I've worked on ALS in the last 30 years. And I work both on the scientific aspects of the disease and also on the clinical aspects, which I think they are very important because we cannot do a good science with having a good clinical activity with our patients.
Thank you, Adriano. And Dr. Kavanagh?
Hi, good morning. It is an absolute pleasure and an honor to be here today. My name is Melinda Kavanagh, an associate professor in social work. And as Kathy said, I'm also a licensed clinical social worker with more than 20 years experience in specifically neurological disorders, the last 10 of which have really focused on ALS and MND. And my area really addresses the often very hidden and vulnerable group, children and youth who are impacted by living with and caring for and being a part of life with someone who's living with ALS and MND. And my research really encompasses that, their needs, their support, and how to build and develop really international interventions and supports for these children and youth. So again, it's my absolute honor to be on this panel with these amazing speakers. So thank you so much.
Thank you, Melinda. Thank you both very much. I'm looking forward to our conversation. But to get us started with the conversation, I have the very great pleasure to introduce you to Orlando Ruiz. He is a person living with ALS-MND in Colombia, and he is also the founder of the ALS-MND Association in Colombia, ACELA, which he still actively leads. And he will share with us what his experience has been living with ALS-MND for 21 years and on preparing for end of life. So thank you, Orlando.
Hello, my name is Orlando Ruiz and I live in Colombia, South America. I want to start by saying thanks to the International Alliance for their invitation to take part in this webinar, alongside Carol, Melinda, and Adriano. Allow me to tell you a little about myself. I was diagnosed to have ALS in March 2001, and I am the founder of ACELA, the ALS-MND Association in Colombia, which I still have the honor to lead. Upon my diagnosis, the initial prognosis was 3 years because at the start ALS progressed very quickly. However, it is now 21 years since my diagnosis, and as you can see, I have some severe physical disabilities, but remain still mentally strong thanks to the love of my wife and my family. Upon my diagnosis, I decided to inform myself from reliable international sources like the Alliance member associations. And 4 months later, once I understood the stages of the disease, I informed my family. At that point, I had not made my end-of-life decisions because I had felt I had to first make a plan on how to live with ALS before thinking of anything else. My first 2 years of living with ALS, I was my support network, as I lived on my own. In the following 2 years, as I became dependent on someone for daily tasks like walking and getting dressed, I went to live with my mother, my sister, and my young niece. It is very difficult to discuss with your mother and a young girl end of life, but I knew that I had to take the initiative to address this topic. As well as my decision towards accepting or not a tracheostomy, I then left it all in writing. I received their support because I explained that all people, healthy or living with an illness, should make their wishes clear in the unexpected event that they could end up depending on a mechanical ventilator. 4 years after my diagnosis, I decided to get married, and because of this, my end-of-life decision ceased to be a taboo for a few people who knew me. My response to them was that for no person can the certainty of death change the way they wish to live, because eventually all people will one day die, regardless of being healthy or not. With this, I want to clarify that discussing end of life does not mean abandoning your life projects or that death is imminent. Since before getting married, I expressed my tracheostomy decision with my wife, and I also listened to her fears and concerns. We have reviewed the decision approximately every 4 years since then, so the end-of-life discussion is not part of our daily lives, but is a topic we openly discuss and address. My advice is that it is important end-of-life is discussed with those people close to you and sharing your ALS journey. Orient yourselves with professionals who are experts in the field and not with people who simply express what they think they would do if they had ALS. Another recommendation is that you set up your advance directive. I have left mine written, signed by 2 witnesses, and inform my wife and brothers that it includes whether or not to have a tracheostomy, whether or not to pursue euthanasia, whether or not to undergo resuscitation in the event of heart attack or accident. I'm not sharing my decision as I do not want to influence the audience. I've listened to hundreds of people living with ALS, and through this experience I know that it is an individual decision and it should not be judged as good or bad. But whichever it is, I recommend you leave it in writing. Legislation is different from country to country and region to region, and this tends to change with time. For example, in Colombia, the legislation has changed 3 times already in the last 25 years. Before I finish, I want to share my top 3 recommendations for people living with ALS. First, do a plan on how to live with dignity with ALS and keep your mind occupied on things you enjoy. Signing an advance directive does not mean abandoning your life plan, but it is something everyone should do. Second, talk openly with your loved ones about your end-of-life wishes in a quiet environment, without anger, without blaming anybody, and without external pressures. Both you and your family should listen to each other and get advice from a palliative care specialist. It is important as well. But ultimately, the decision belongs to you, the person living with ALS. Your advance directive can be changed, so you can change your mind. Just destroy the old document and sign a new one. I will add that I have been in critical situations that could have ended my life, and I understand that the fear it brings and how scary it feels. So be good to yourself and your loved ones when discussing end of life. Having a clear advance directive is so important because you don't know when your time will come. Having to decide during an emergency and under pressure can cause some serious psychological problems. Take the opportunity for dialogue while you're alive. And for believers in the afterlife, you don't want to end up thinking, we should have talked.
Thank you, Orlando, for sharing your experiences with us. You've covered some really important and sensitive issues regarding end-of-life discussions and decision-making, and highlighted some of the difficulties, but also some of the positive outcomes of having these discussions with loved ones. A great way to set the scene for our conversation today. So thank you very much once again. So I think a good place to start the discussion is to ask you first, Adriano, why end-of-life discussion is so important and why people may be afraid to have these discussions.
Oh, thank you for this question. But first, I want to say that Orlando's experience are so important because he expressed in a very clear way what happens with patients. So I think he has already responded to everything, but I want to say something more about that. The point is that from the point of view of end-of-life discussion is a matter to define the disposition, the choices of the patient, of the people living with ALS and their families also. It's very important because there are so many choices. Well, it's obvious there are differences between countries, regulatory aspects, but anyway, there are a lot of choices that are related to the different possibility to work with the patient and to help them. Also, for example, PEG, enteral nutrition, is a choice which is not considered in some way in end of life, but is considered in a quite late part of the disease. The end-of-life discussion should be something related to the make the patient to be empowered to make the choices in the right way, which is something really personal. there is not a right way, general right way to choice. There is a personal way, which is also shared with the family. In some way, it's important to have the possibility to make a plan, a shared plan of care, keeping into account all the aspects of what will happen possibly. And Orlando experience is quite clear. It's something that can happen early, can happen very late. We don't know, but have the idea to have this possibility to choice is important. The second part is afraid. Well, we can consider three characters in this story. One is a person living with LS, the fear. The second is the fear of the relatives. And the third one, which is not less important, is the fear of the doctors. Because to talk about this aspect is always difficult, and is another point that we should consider. It's quite obvious a person living with LS has fear of suffering and fear of death. And we have to talk about that in the best way we can. The second one is relatives. It quite often happens that relatives come to us. They ask, please do not speak to our relative with LS, because he cannot bear this emotion. But we have to explain them that it's their fear. We need to talk with the patient. We need to discuss in the best way we can, but it's an information we have to share. The third is our fear of disease, fear of death, which is something that for some people is very difficult to discuss. It's something that we as physicians, as doctors, we have to learn, as psychologists, as allied professionals in general, we have to learn to face also these aspects.
Thank you, Adriana. Yes, some really good points there about the different aspects of fear, that it's not just about the patient and the family, but it's also our own fears that we have to face and come to terms with as well when we're having these very important discussions. Melinda, what about from your perspective? Why are these discussions so important, and why may people be afraid?
Yeah, you know, it's hard to go third after those two really wonderful discussions. And I have to also absolutely thank particularly Orlando for his insight, very specific, very thoughtful, well said. I think the only thing I'll add is, you know, agreeing with everything that's been said, but in my experience, talking about death and dying and end of life it's very fearful. It feels like you're losing your own autonomy and your own ability to make choices. And society as a whole really doesn't encourage those kinds of conversations, because it's pretty much the one thing that none of us know exactly what's going to happen. So the only thing that I would add to that is particularly engaging children and youth and family members, being very open and honest about your own feelings and your own fears and your own concerns. Oftentimes, why people are afraid to discuss it is because they're afraid to hurt or offend or bring some sort of negative emotion to their loved one with ALS and MND. And so, you know, because there's that fear and that concern, then the communication just doesn't happen. And as Orlando said, you know, it can happen very late. And when it happens very late, then there are lots of issues with real complicated grief and often anger. So I think that why people are afraid to discuss it is we as a general society don't put it out there in part of our just everyday discussions. We reserve it for this somehow special, specific conversation when it should be interwoven throughout your conversations in a very normalized, engaged, honest way.
Thank you, Melinda. That's yeah, some really important thoughts you've brought up there, and I think it really does highlight just how complex these discussions are, and so many different emotions come into it, and considerations and thoughts, and we're just not used to talking that way, are we? We're really not. No. It's hard, very hard. So my next question is a three-part, well, it's almost four-part question actually. What do you as health professionals consider when preparing to talk about end of life with your patients? When do you think the discussion should start, and how do you approach the conversation, and who do you involve in those conversations? Melinda, do you want to start off this time?
Absolutely, and I appreciate the opportunity to integrate the healthcare professionals, because as I said a moment ago, you know, as society writ large, we are awkward and uncomfortable with this conversation, and frankly, that includes healthcare professionals. So one thing I always like to say is, look and know thyself when it comes to end of life. What are your thoughts? What are your beliefs? Because those can very easily be translated to your patient, your family, and just be comfortable with how you feel about these really large and complex topics, so that when you are having that conversation with your patient and their families, that it's really a very thoughtful and open conversation, and you aren't feeling as uncomfortable as they might also be feeling. When you think about when that conversation should start, you know, I am, as a clinical social worker, I spend all my time with the children and the families and the caregivers, and I talk to them frequently. And in my research, we find that those conversations need to happen as early as possible. So if you're working with families or you're in a clinical setting, you know, really encouraging the families to have them soon. And when I say soon, that's also at a point when the patient needs to be able to have that space to understand how they feel about their own impending death or dying process, right? And so when we say have those conversations soon, it needs to be at a point where the patient has also had time to process that and has had time to kind of feel where they are. But we want to be able to make sure that that support is really surrounding the family as a whole. And so when you have those conversations sooner than later, then those stressors, those questions, those fears, those concerns can be addressed along the way. And the best way to approach these kinds of conversations, as hard as they are, is honest and open. And oftentimes people are concerned about doing that because then that leaves the door open for their own emotion and their own expression of fear and concern. And particularly when it comes to dealing with children and youth in the families, we're afraid of that. And we don't want to show our own fear and concern and anxiety to them. But by being open and communicative and showing how we feel about it, we being the patient, the adults in the room, then we're allowing our children to be able to ask those kinds of questions and to be able to engage themselves in a very open and honest communication. And that we hope to stave off some of those really complicated and negative impacts of difficult grieving later on. So I would certainly say have the conversation early. I would have the conversation open and honestly, and as the healthcare provider, you know, really know where you're coming from as far as your own perspectives on death and dying.
Thank you, Melinda. Yeah, it's also about looking and listening for those cues, isn't it? As a health professional, so really waiting and encouraging those conversations as well. Adriana, what about you? What do you consider when you're preparing to talk about end of life with your patients?
So no, really, thank you, Melinda, because what you said makes it easier for me to talk about this point. Well, we usually say the earlier the better for everything for every disease really, but for ALS in particular. But the point is that we need to tailor our decision to start to talk according to the patient characteristics and the family characteristic also. That's not really easy. It can be done if you have a good knowledge of the patient, of the family. The good news is that we see the patient every 2 months or 3 months sometimes. So we have the possibility to meet her, to talk with meet them, to talk with them, to understand who they are, from where they come, and where they are going, where they would like to go, because it's very important. That is a sort of a movie of the patient, and we can try to understand what are the instruments, I mean the psychological instruments they have to understand and to face these aspects. What is their education also level, because that's important in terms of terminology, their social level, what support they can have during the process, and all the psychological aspects. It's not easy, but we are what can we do is to know the patients, to have the help of our psychologists, because they meet the patient and they can have other information. We share the information, and also with the nurses, social workers, because they have other perspective of the patient, and so putting it all together, and this is the answer. All people working with the patient should be involved. Well, not the final, well, the official discussion, I mean, but they are all involved in understanding better what we can do for being of help. How to speak? Well, it's not very easy usually, but we usually say we use a hierarchy of euphemism. So going from something which is very easy into something which is more complex, and with a sort of back and forth message. What is very important is not very used, but is to listen to patient and the family, and listen to verbal and non-verbal messages, because they are very important. I mean, non-verbal messages, non-verbal communication is often more important than the verbal one, because you can understand, is the theorem of mind, you can understand what they really feel about you are discussing, and so you can better tune your communication. It's not easy, but it's something that we should effort to do for being on higher help for them.
Thank you, Adriana. Yes, that's a really good point you made there around trying to tailor the information and to tailor the conversation to the patient and the family and the dynamics within the family as well. I think that's very important. And for many people, I think it's tailoring, but also giving just enough information that's wanted and needed at that time, and then following up that conversation at a later date when they're ready as well, I think, isn't it? Very complex. And certainly highlights the importance of having a multidisciplinary team working together with the patient and the family, doesn't it, as well, when you're having these conversations. So on to the next question. We've discussed the importance of honest and open communication with the family and the person living with ALS-MND, and the very complex nature of making decisions about future care. Orlando also highlighted the very individual nature of end-of-life care planning and the need to review plans on a regular basis. So I'd like to ask you both now a question about advanced care planning and decision-making. Specifically, Adriana, who should make the decisions about care at end of life? And what's the role of the carers and family in making these decisions? And how should they be involved in that decision-making process?
Yeah, no, that's a very important question. Well, the first point is that from the legal point of view, the decision is up to the person with living with ALS. That's clear. We cannot have a surrogate decision by the family and so on. But the other point, which is the human part, is that a person is, as a human, is a social entity. So that does not usually live alone, but lives with the family, with friends. So the decision should be shared, in my opinion. What we do usually is to have a discussion in presence of the person who are the most important for the patient. We are always ask them, do we want to have person with you? And sometimes they are, most of the times they are relatives, sometimes are friends. That can be present, because a friend of a life is sometimes very important for every decision. And the discussion should be done in a way to give the possibility to all the parts to make questions. So maybe could be 1 hour, 2 hours. We don't know when we start to discuss. And in my opinion, the final decision should never be given after this discussion. We always say, I always say to patients, well, now we have discussed, you have, please come back in 2 weeks, maybe, or what you want to call me. We can organize another meeting when you have taken your decision, because they sometimes say, well, I want to do that. No, please do not have this decision now. You are overwhelmed by information, emotions. Please wait and come back with your relatives, your friends, to take the final. The final is not really final. Well, what you have decided now is not final, because you can change mind during the course of the disease for reasons that are different. There are a lot of reasons why they can change mind. Again, they have the possibility to discuss again and to start again the discussion, making more questions. I think that's it's again not a picture, snapshot, but is a movie again that we have to consider in this case, and to give the possibility to reflect on this, and to have the possibility to talk with other people and so on, to share experience, maybe sometimes can be useful. In my opinion, this is the way the decision can be taken by the patient.
Thank you, Adriano. And Belinda, what are your thoughts on decisions at end of life?
I agree everything with what Adriano has said. I'll add a little bit more about kind of my experiences with the children and youth and the kind of extended family member. And I think one of the most critical pieces that's been brought up, and I don't think we can highlight it enough, is that this isn't a one-time decision, that this is a conversation and this is a process, and it needs to be made, really clear, and that support provided, that, it's going to ebb and flow, and decisions might feel like they're made and then they'll decide something different. But engaging the family as a whole is really very critical. And, a lot of the research I have done really shows that children and youth want to have these conversations. They say explicitly they want to be a part of it. They want to know what their family member wants or doesn't want. They want to understand that process. And so often we don't include them in these discussions out of concerns or fears that we are protecting them, that we don't want to upset them. But the reality is they're very much part of that process. And by bringing them in, not to make the primary decision, to Adriano's point, that is absolutely up to the patient, but to be a part of the discussion. And, what we know is that all of these family members, young children, all the way up to the adult caregiver, they're seeing these changes. They're seeing these kind of incremental losses. And so to be able to bring them into that conversation to say, this is how we understand how things are changing. What do we want it to look like at the end? What does that end even mean for us? How do we, as a family, as a friend support system, prepare for that? Because what we know about ALS, depending on the person, depending on where it begins, it can go fast, it can go slow. So we want that family and those friends to be able to be a part of discussing what they're seeing, those changes and those losses, and that real, true, often very difficult anticipatory grief that they're feeling. And if they're left out of those not necessarily final decision making, but if they're left out of that conversation, then that grief can be very manifested as anger and frustration. And that's not fair to anybody, to the patient, to the family member, to the child, to the youth. So really asking those family members, including those children and youth, very much so, what do they know? What do they want to know? And how do they want to be a part of that process? Because it's often very surprising how often people really do want to engage and participate and support. And so having that kind of collective conversation around the decision making is really, really important.
Thank you, Melinda. Yeah, I think you both really highlighted there the importance of having those ongoing conversations. That it isn't a decision made at one point in time may change. And so those open and honest conversations, again, are so very important. And Orlando, I think, mentioned in his presentation the importance of writing that down, writing decisions down and then reviewing those plans on a regular basis. And I think certainly here in Australia, we do have advanced care planning websites that you can go to that you can help step you through that as well. So there are a lot of resources that can support the person and their family and the children as well in having these discussions, making these decisions, and then reviewing them on a regular basis. I think some of those resources are being put up in the chat room as we speak as well. We've touched on fear quite a bit so far in our conversation. What are some of the common fears people express as ALS-MND progresses and end of life approaches? And how do you address these fears? Adriana, do you want to start off? You're on mute, Adriana.
Sorry, that's again a great question and a very difficult question because it depends on the different people. But anyway, the first fear is suffering, to have pain, for example, and to lose the abilities if we are talking very quite early during the course of the disease. What are the abilities I am going to lose? When I am going to lose the ability? What will happen? And to become dependent is another really problem, dependent on other people. We have to consider that most ALS patients are between 50 and 70. So they are people still active. They are people that sometimes have a good work activity. They are very important for the family also from the point of economic point, financial point of view. That's a strong fear. Pain is another, I've already mentioned. It's very important because we can say, well, pain is not common in ALS, but can be present. So it's very important to explain that they have to talk about pain if they have this problem. We can treat it. Overall, the point is that we have to discuss about the possibility to do therapies for most of the symptoms. And this is a part that is relatively easy. What is very difficult is the problem related to the loss of autonomy. We can help the patient with that. There are very important, very useful instruments for that. Electric wheelchair, for example, to maintain mobility, autonomy. But that's something that has been to be explained very, very well. Another fear is related to the family suffering. A lot of patients share this point. They feel that family members are going to suffer also because of the burden they are going to have. And family, also from this point of view, is very important because it's a part of the disease, but it's also a part of the therapy. Sometimes we need to mediate between family and patient in order to make them to understand that also the best choices for them. But that is something. There are two fears in this point, from this point of view. It's a struggle of two different fears, and it's not very easy to make a reconciliation between these two aspects. But I think Melinda will explain better than me this point.
Oh, I
you.
love this. This is such a great partnership. I'm just nodding. I'm like, yes, everything he's saying, everything he's saying. Yes, the family, there are some very specific fears that the family feels. And often those fears surround the loss. What is my family going to look like when we lose our loved one? And the fear of forgetting them, the fear of moving beyond them, that fear of I'm going to be living my life and their life is over. How do I reconcile that? And for our families, that can be a real struggle because they also fear making it about them. They don't want to say so much about how this is affecting me and how I'm feeling when their loved one is moving towards the end of life with ALS and MND. So as Adriano said, there are these really two kind of primary factions, if you will, and they don't always overlap because, as we said very much earlier in this conversation, being open about end of life and death and dying is very difficult for a lot of our families. So to repeat some of the things we've said, it's very specific to family. It has everything to do with someone's culture, their spirituality, their religious beliefs, really engaging those, because those are often either a source of or a balm to the fears that our families really feel. And so if they have that concern that they're making it about them, or if they have that concern that their life is just going to keep going while their loved one isn't, those are real, almost existential fears that need to be addressed. And, through kind of a holistic team-based, using the physicians, using the social workers and the nurses and the psychologists, really addressing that, because without addressing these kinds of fears, again, that's where we get real complicated grief and some real struggles with long-term outcomes in those family members, including our children and youth.
Yes, thank you, Melinda. Once again, highlighting that importance of the honest and open communication and conversations, and engaging the family, but also seeking that support and help from the multidisciplinary team, so that they are getting the help when they need it and if they need it. So I guess that leads very well into our next question around emotional support, and just how important emotional support is from diagnosis onwards. But particularly at end of life. But I think if you get that emotional support early on, it helps as you progress through the illness. So it really is key for PALs and CALs. What type of emotional support might be available to people living with ALS, MND and their families, and when should they start to seek that support? Melinda, could you kick off?
Absolutely. It's a great segue. What types of support are available? So this can be a complicated discussion given that we are an international community. But one thing that's fairly consistent is that team around the patient and the family, really reaching out wherever you are, that ALS and MND clinic, accessing as many individuals there as possible. And for the children and youth, that's always the perspective I'm coming from. It can be very difficult because a lot of our clinics around the world don't have very specific personal support or immediate engagement. And one of the things that I've worked with my colleagues around the world on is to put together a real solid grouping of supports that are in book form, and they address all of the end of life issues and death and dying for the family, for the children across developmental stages, so that as they grow, they can be able to express and understand kind of how they feel about it. I also highly encourage, always encourage families to engage their schools, their school systems, systems, particularly for, their younger children and youth. This is where our children and youth spend the majority of our time. And, talking with the school personnel and letting them know what's going on, so that if you do see some changes in your child or your youth, that they'll understand what the root of those changes are, and they'll be able to provide those kinds of supports. And as we have said all along, those supports need to be offered early and often, and not waiting until kind of a major thing has happened or a major progression, even earlier towards diagnosis. I know we're talking about end of life, but quite frankly, it's all part of the same continuum. And so as early as possible, addressing it by age group, helping your children and youth, even very, very small children, feel the emotional changes, feel those differences and those little losses. And, again, I feel like I'm a little bit of a broken record, but I'll say it one more time, particularly with children and youth, that anticipatory grief can really manifest itself in anger and self-isolation, because they see those losses, they see those changes. And without the opportunity to talk about it, without the opportunity to read about it in any of our resources and our books, or without the opportunity to talk to and be supported by another adult, that can really stay with a child and really cause some long-term emotional struggles. So you want to do that early, you want to do it often, and not be hesitant to engage as many of the wonderful healthcare providers, allied health, ALS, MND organizations as soon as possible in this support, because it's just so critical, particularly for our family members.
Thank you, Melinda, and thank you for highlighting the need to engage teachers and schools in supporting children. I think that's really important to let them know what's going on, and they can then monitor the children and help support them emotionally through the journey. Adriana, what about you? What type of emotional support might be available to people living with ALS, MND and their families?
Yeah, well, as Melinda clearly highlighted, each ALS center has to offer a support earlier, maybe after the diagnosis is revealed. I say offer because not all patients want to have support. They feel I do not need a psychologist to go. The point is that, again, you have to offer, well, not at every visit, but sometimes during the course of the disease if they deny it. And the psychological support should be offered also to the family members. In our experience, they are much more eager to have support than patients. They want to have it because they have a lot of problems in facing the disease and facing their feelings. But anyway, the first question the patient has in terms of psychology is why me? Why myself? What happened? And that's very important because we can say as physician something about the mechanism of the disease, but this is not the answer. The answer is something more internal, to understand that it's something that happened, just happened, that there is no reason why, but they have to face this aspect. It's important to give written information, well, patients in general like more to have a face-to-face discussion. Again, because it's more human, because you can have a different support. In this terrible period of the COVID-19, we also started to have a web-based psychological support, which has been accepted very well by the patients. They were quite happy to have it. Also because it's useful for patients that live quite far from the center. We follow, for example, patients from other regions, and they are maybe 3 or 4 hours by far from our, so they couldn't come for this support, and now they can have support by our psychologist. I have another point to say. It's not only of emotional support, but also of educational support. both for the person living with health and for the families, because of the fake news they have about the disease. I mean, not about the therapies and so on, which is a real problem, but sometimes they read something that is not correct about the disease. So they have fear that they are not justified. So educational support becomes very useful. We did that before COVID-19 with educational groups, patients and family members discussing together. And it was very useful because there were also solutions for the problems that came from the family and from the patients, and not from us, because we do not live every day with them. So we can imagine something, but it's just imagination. It's not what really they have to face. And it revealed to be very useful really for them. They were quite happy for the open discussion between them. In this case, the psychologist was a moderator only of the discussion.
Thank you, Adriano. Yes, lots to unpack there, but I think it's what the key message is to let people know that there is a lot of support available. I think that the ALS MND associations are a good first port of call for people to be linked then with the types of support services that may be available. And as Adriano highlighted, COVID-19, I think, has really expanded the types of support that organizations and clinics are able to provide, so that it can be provided more widely and more often to people through virtual means and etc. And also, I think you've highlighted there, Adriano, the real importance of peer support, the sort of support groups where people can come together and share their experiences and encourage that communication and conversation, and also talk about where they can go for that trusted information, access to trusted information and education. And I think another source of great support is palliative care services, palliative care specialists. So it might be now a good time to sort of clarify the role of palliative care and how that relates to end-of-life care. Palliative care is sort of generally described as holistic and family-centered approach to care with the aim of supporting the health, psychosocial, spiritual and emotional well-being of people with life-limiting conditions, to help them maintain their quality of life and also achieve a dignified death. And I think we know that research has for many years confirmed the benefits of introducing a palliative care specialist or a palliative care service from diagnosis onwards for people with ALS-MND as part of the multidisciplinary care team. The palliative care team may then become more involved in providing more specialist care and support to pals and CALs as end-of-life approaches. So I'd like now to talk about why palliative care is important and what are some of the barriers to accessing this type of care. Adriano, do you want to start that conversation?
Yeah, well, it's quite clear that palliative care is a very wide, really, concept.
Mm-hmm.
It starts from the therapy of symptoms, symptomatic therapy, which is most of the therapy in ALS, by the way, unfortunately, and is also includes end of life, but not only end of life. Mm-hmm. So it's important because it's based on the idea of reducing symptoms, alleviate symptoms, and improve quality of patients, and also help the family to live better the disease. If we go to end of care, it's something that is end of life. Sorry, is something that is very complex because there is no a single answer because of the different health system and different situation we have. It's clear that the involvement of palliative care specialists is very important. and should be quite early during the course of the disease, because in my opinion, it's very important that the palliative care specialist is not a figure, it's a person that comes at some point of the disease, I mean at a very late point, but is part of the group. It should be perceived in that way by the patient and the family. I think that that's something that should be completely different from oncology. In oncology, usually there is a sort of break between the therapy, so the oncologist, and then the palliativist. In ALS, is something that is, you have a growing importance of the palliative care a person during the course of the disease, but is a person that should be already present in the first part of the disease. Obviously, there are completely different situations in different countries about palliative care. And also, I can tell you in Italy, from one region to the other, there are huge differences. The struggle we have to do with the ALS Association is to make palliative care possible for every patient everywhere. Another point is what are the possibilities to do in terms of different type of palliative care, also of withdrawing from cure. For example, in my country, only in the 2017, we had a law allowing the stopping of tracheostomy care, only in the last 5 years. But in most countries, not possible. And also assisted suicide and so on is completely different from different countries. I don't want to tell that we need to have this everywhere, but this is a discussion we need to do among all people that is involved in the care of ALS, because it's something that we have to understand better and to understand according also to the different characteristics of the country. I mean, the social region beliefs and can be different. So this is another point, but we have not really an answer now. It's just something that we have to discuss.
Thank you. Melinda, why is palliative care important from your point of view?
I think palliative care is important because it is an opportunity to engage the whole family. It's something that really, as you described it, Carol, as being holistic. And so again, the earlier we can engage our palliative care specialists, the more opportunity we're providing our families to be able to come together to understand, what does our loved one want at the end? What does death look like? How do we support them? How do we manage pain, the process, the grief? And that's why I'm a huge proponent of palliative care. And, you know, there are a lot of barriers to it. And one of the biggest barriers, you know, we certainly see this here in the US, is that people think that palliative care means you're giving up and you're going to die. And that's simply not the case. That, you know, as you described and as Adriano described, it's a really beautiful opportunity for patients' wishes, for pain management, for, you know, really engaging the family around this final process. And so I think if there's anything we can do as healthcare providers is to strongly encourage our patients and families to engage as soon as possible with palliative care and not approach it as I'm giving up or this is the end, but approach it as this is another opportunity to have that holistic support around us, our family, our friends, and really engage. Speak with your physicians, speak with your allied health professionals. How can you engage those palliative care specialists?
Yes, thank you. I think you've both really highlighted the importance of engaging those palliative care specialists early on in the disease process, but you've both also highlighted the barriers there, that there are barriers, that there is resistance from people with ALS, MND and families to be referred to palliative care. It does sometimes bring up the fear that, you know, they're near the end of life, where in reality it should be part of the multidisciplinary team right from the start. but also the barriers around access. You know, for many countries, access to palliative care is very difficult. And even here in Australia, you know, it varies from region to region in how you're able to access these palliative care services. I should note that it's actually National Palliative Care Week here in Australia as well. And, you know, it's, so, you know, it just highlights just how important those conversations around palliative care are, to break down those barriers so that we can have more open and honest conversations about living with life limiting and terminal disease and end-of-life care. It's really important. And it also then relates to bereavement support. If you're linked in with a really good palliative care service and team, that ongoing bereavement support can also then be provided, hopefully, if that's available, because that's so important for carers and family as well. So we're nearly time for wrapping up before we go to questions. When Orlando in his presentation concluded with his top 3 recommendations for talking about and preparing for end of life. So perhaps you could both give us your top 2 to 3 recommendations for people living with ALS MND and their carers and family. Melinda, let's start with you.
Yes, I think my absolute top one is to talk early, talk openly, and talk honestly as a family with all of your family members. It doesn't have to be a one-shot conversation. It doesn't have to be the be-all, end-all, or the most intense conversation, but bring it up. Be open about it, be honest with it, and be willing to continue having the conversation. The only other piece I would add is that caregivers, whether they're adults, whether they're children, or older adults, middle-aged adults, however old they are, they all deserve the same level of support and engagement, both during the process of the disease and after. I love, Carol, that you just brought up the issue of bereavement, and that can be so very complicated. So having the conversation openly and honestly as often as possible, and making sure that you as the caregiver are reaching out and getting that support you absolutely deserve, even after the loss of your loved one.
Thank you, Belinda. I like that. Early, openly, and honestly. That's a good top 3. Adriana, what about you?
Well, I would say to Pals and Carls, make questions, make questions, and make questions. These are the top recommendation. Always, I mean, with every single member of the multidisciplinary group. This is very important because they need to have all the information they want. Second, to share their fear and doubts, because it's important. We need to know because they are different. We have just discussed. We cannot imagine what they feel. A third recommendation is only related to caregivers, is please take some time for yourself, because they feel guilty to try to keep their life, because they feel guilty because the person with ALS they are caring for, they feel they are taking away time from the activity of a caregiving. But if a caregiver does not take time for him or herself, is going to have a breakdown. So this is very important. Something that should be explained by us in terms of professional working, and to make them understand that they still to have some part of their life, because they are going to have after all this process, after of this day, they to take again their life. So this is, I think, one of the most important points for the caregiver.
Thank you, Adriana. Yes, that is just so important, isn't it? For the carers to take that time for themselves and to seek support and help with caring for their loved ones, particularly at end of life. It is, you know, a community of caring is needed, isn't it, for people with ALS, MND and carers, and to surround themselves with those people that are going to support them and help them through this very difficult time. So thank you for answering my questions. Now we'll see if we can take some questions from the chat, from the Q&A. I can see a few questions have been put in there. Oh, I've just got to have a look at the chat. Where is it? There it is. So what's question number 1? Is there information on mean disease duration and gender on end-of-life decision in patients living with ALS? Adriano, do you want to try and tackle that one?
Yeah. Well, this is yes, we have some good algorithm that give us the possibility to foresee in some way what will be the duration, the time for end-of-life decision, also according to gender. There are not so much difference between gender from that point of view, but there are. So theoretically, we could disclose this information with patients. But the point is it correct? Because this is to give a number. I don't think a number is an information. To say maybe in 36 months, you are going to need to have palliative care or something similar. This is not giving an information. This is on the other side. I think it's to escape from giving an information. The information must be more complex than a single algorithm number or similar. Also because of the quite large differences between patients, the heterogeneity of patients. But anyway, what is important is to give a general idea what will happen according to the characteristics of the patient. Well, you are going. The situation, your disease is more rapid or less rapid than the median. So probably something will happen before or something will happen after. We have to see what will happen at every single visit. This is my opinion. It's not shared by everyone. We had within the European group, we had a very strong discussion about that. And the other people in the European group feel that is useful to give just a number to say that's what we expect from you. But I think Melinda can say something about that because and also you, because it's well, I don't know, but maybe the patient should say that.
I think it's a really interesting discussion. I certainly don't have any, data on this. I think whether it's end of life or, any other big emotional, communicative issue, depending on how we identify as a gender across the continuum, we certainly respond differently. And perhaps, disease duration or gender and end of life decisions, I think it's very complicated. I certainly don't have any answers, but I think going back to something you said earlier, Adriano, is that, it's very individual. Perhaps that's the only thing I'll add to that conversation.
Yep, I think that's certainly true, isn't it? It is very individual, and I think it also how much a person wants to know as well, isn't it, when you're talking about disease duration. Yeah. We've got another question here. How can we approach the end of life discussion when there are mental health issues like depression? Melinda, do you want to start?
Yeah, this is such an important topic. I'm really glad whoever asked this. My immediate feedback is whenever there is an existing mental health issue, that has got to take priority. You need to make sure that there is, if the individual is on medication, the medication is appropriate, that there is the right amount, that they're taking it appropriately, but that they're really attending to that mental health issue as a priority, because we do know everything we have have just said about end of life can be very overwhelming, can be very stressful, can be very fear-based. So don't hesitate to make sure that whatever mental health issue is currently existing, that is very much addressed, that you're getting the psychological support, you're getting the therapeutic, the medication support, so that then you can start having those conversations and really kind of managing and dealing with end of life. That said, you know, these are very complicated discussions, and they can bring out or maybe exacerbate some existing mental health issues, diagnoses, complications. So being very, very aware of any change in your mental health, not hesitating to reach out for that support from your physician, from your psychologist, from your social worker, as you see those changes, because that is going to be absolutely critical that gets attended to as you process this end of life, whether you're the caregiver, whether you're the person with ALS, doesn't matter. Please be very aware of any changes in your mental health and be immediately thoughtful about getting that support, because you certainly deserve it.
Thank you, Melinda. Adriano, have you got anything to add?
That's a part of one of my answers before. We need to understand the emotional and psychological aspects of the patient and the family also. Again, caregivers are very important from that point of view in order to better tune our discussion about end of life. In general, we as neurologists, we are quite generous in treating the patient for depression, and the drugs are very well accepted usually. Most of the patients well accepted this type of drug, and they have now the last generation of antidepressant have very few side effects. So to be a little bit more generous is important when there are some signs of depression. Can be also very useful, because the patients start to react better to the disease. And it is again very important, because the reaction against the disease, I would say, is something that makes the difference in terms of the cause of the disease.
Thank you. Yes. Now we do have another question here. What is your recommendation for those that are going through the loss of their loved one, especially after having lived themselves as an ALS as a caregiver and now have to move forward? So Melinda, I think you've talked a little bit about this. Do you want to elaborate a little bit more?
Sure. It's such a thoughtful question. And I think, you know, we've certainly addressed some aspects of it, but this is a big issue with our caregivers, because oftentimes our caregivers, regardless of the disease, but very much so in ALS and MND because of the intensity of care, there's almost an intentional or unintentional taking on a persona of caregiver, so that when that loved one has passed away, oftentimes our caregivers feel that sense of, well, who am I? What am I doing? And how can I move forward? Because so much of my life was structured around care. We see that in our children and youth as well. So this isn't just an adult caregiver issue. So I would say that the most important thing you can do is reach out for those peers. Find those support groups that are engaging ALS, MND caregivers, and talk to others who've been able to go through that process as well. And know that it's a very normal experience to feel, who am I? What am I doing? What is my kind of life's purpose at this point? Because so much of what had my life has been structured has been around that care. And I think this goes to an earlier conversation that Adriano brought up, which I could not agree more. During that care process, find those ways that you can still be you, whomever that is. You know, is it going for a swim, going for a walk, getting some sort of respite, talking to friends, so that you can maintain that interest in other things and that engagement in other things? Because when that eventual loss comes, it can feel like the entire rug has been pulled out from under you. So please engage in other support, peer-to-peer. Support each other, learn from each other, and be able to re-engage.
Yes, that peer-to-peer support is just so important, isn't it? And connecting with other carers and other past carers and supporting each other. Adriano, have you got anything to add to that?
I completely agree with Melinda. Some caregivers do not want to have help because they feel guilty to have help, and that's very important. They need to accept to have other help and again to preserve time for themselves. Several years ago, I made a study on the caregiver burden during the course of the disease, and what I used a scale on with different domains, and they were time dependence, developmental, physical, social, and emotional. And what is interesting, the most impaired was the developmental burden, which is the feeling of the people to be out of their life, to have not the possibility to control their life, the locus of control in some way. And these were the caregivers. And this feeling increased over the course of the disease. And so to have the control of their life, it means to have something for themselves again. It will help what will happen after this terrible experience. It's the only way to be in life, to preserve friends, to preserve some activities, and don't feel guilty if they do that.
Thank you, Adriana. That's just so important, isn't it? Really important point to end on. I think it was time to wrap up now, but thank you both so much for your really thoughtful and insightful discussion today. It's been a complex and difficult conversation, but I think we've covered a lot. But I think you really have highlighted so many important aspects of approaching end of life and decision making and finding and seeking that support as people with ALS MND approach end of life, and support for the family, the children, the carers. But I think the most important message is that there is support out there, that the multidisciplinary team is there to support the family, to support the person. Palliative care services and ALS MND associations are all there to support people throughout this process, throughout the end-of-life process and through to bereavement as well. So I think that's a really important message to end on. So thank you all very much. And thank you to everybody who's tuned in today for listening and for your very thoughtful questions as well. Thank you to Jess and Kathy and the Alliance for putting on this webinar series. I think it's been an absolutely terrific series. Really important information there for the ALS MND community worldwide. So thank you all for what you've done. Recordings will be available on the Alliance YouTube channel for those of you that want to tune in again and listen again, and for those that missed today's live recording. So thank you all. I wish you all a good day, a good afternoon, and good evening for me in Australia. And thank you all very much once again. Bye-bye.
Thank you.
Thank you very much. Bye-bye.
Bye-bye.